بسم الله الرحمن الرحيم. Assalamu alaikum everybody. Today's presentation will be about the actions and clinical application of directly acting sympathomimetics. We will talk inshallah about the specific property of each sympathomimetic and its clinical application. So, in quick revision of what we have covered in our last presentations, we said that sympathomimetics drugs which produce action similar to the activation of the sympathetic nervous system, they are either directly acting sympathomimetics or indirectly acting. Directly acting sympathomimetics when they act as agonists on adrenergic receptors. We said that they are either selective or they are non-selective. By selective we mean they act on one adrenergic receptor, and by non-selective we mean that they act on more than one adrenergic receptor. Indirectly acting sympathomimetics, on the other hand, they act by increasing release of noradrenaline from the adrenergic nerve terminal. Okay. Also, we talked about the general actions of sympathomimetics, and we have said that these actions are dependent on what type of adrenergic receptor stimulated. We have said that alpha-1 receptors, when we stimulate the alpha-1 receptor, usually we get an excitation except in the intestine. We said that alpha-1 activation will always result in activation or excitation except in the smooth muscles of the intestine. Alpha-2, on the other hand, we said agonists or receptors. We said that they are inhibitory in nature and therefore they are sympatholytics. They are not sympathomimetics. Okay. Third type, beta-1 receptor. We said that beta-1 always they are linked to cyclic AMP and they will increase in intracellular calcium, and they are mostly excitatory everywhere. And we said that beta-1 receptors, they are very important in the heart, where they produce acceleration of the heart rate, contraction, and conduction. Beta-2 are always inhibitory, and we said they produce inhibitory, they produce relaxation most smooth muscles of the body, and although they are linked to cyclic AMP, but they act through the protein kinase A by increase the activity of the myosin light chain phosphatase, and they lead to relaxation of the smooth muscle. So these are generally what we are talked about last time. So we talked in general actions on the smooth muscles of the bronchioles, of the eye, of the blood vessels, of the uterus, and we talked about the action on the heart and as well action on metabolism. Today we'll speak about the specific action of each sympathomimetic and its vital clinical application. And as we will see, there are very important clinical application of this group of drugs. So the major goals of today's lecture: first is to know the actions and clinical indications of directly acting selective alpha-1 agonist, beta-1 agonist, and beta-2 agonist. Also, we will discuss the actions and clinical indications of directly acting non-selective sympathomimetics. Especially, we will concentrate on the adrenaline and the use of adrenaline Noradrenaline, and Phenylephrine. So we start with the selective, directly acting sympathomimetics, especially selective 1 alpha 1 agonist. We have many examples, but we will take only 3 examples, very important example. First is known as methoxamine. This is actually, it is an old drug, but still used in certain clinical application. We'll talk about as well another most modern, midodrine, which is used in certain cases of orthostatic hypotension, as we will see. And the third drug, which I don't favor to classify it in this class, which is phenylephrine. And phenylephrine I will keep to the last because I think it's not a pure alpha-1 agonist. It has alpha-1 agonist activity, plus it has a beta activity, as we will see later. So we'll keep phenylephrine. Some textbooks, they classify phenylephrine as an alpha-1 agonist, but we leave it as non-selective adrenergic agonist, as we will see later. Okay, so let us concentrate now on methoxamine and midodrine. Methoxamine and midodrine. Of course, they will have an action, alpha-1 action through all over the body. For example, on the eye they produce mydriasis, on the GIT they produce inhibition of intestinal motility, etc. But the most important action that we are looking for is their action on blood vessels. So what do you think will happen on blood vessels? As we have said, smooth muscles of the blood vessels, they contain alpha-1 receptor. Alpha-1 stimulation will result in vasoconstriction. So these drugs, by acting as an agonist, methoxamine and midodrine, by acting as an agonist on alpha-1 receptor, they produce vasoconstriction. Vasoconstriction, most important, the vasoconstriction of the small arteries, which are the arterioles. This constriction of the smooth muscles of blood vessels will result in increase in peripheral resistance. And as we know, increase in peripheral resistance means increase in blood pressure. So these drugs, the net result is an increase in blood pressure as a result of vasoconstriction, which will increase in peripheral resistance. And we know that the peripheral resistance, usually it is abbreviated as PR. So peripheral resistance is increased, and this will lead to increase in blood pressure. As a rule, we take it as a rule, any drug which has a pure pressure effect, i.e. it has a pure agonist activity at alpha-1 receptors, usually they stimulate the baroreceptor reflex, and baroreceptor reflex, and this baroreceptor reflex will result in what's known as reflex bradycardia. Okay, so this is the second effect. The first effect, a direct effect on the smooth muscles of blood vessels. They produce vasoconstriction, increasing the peripheral resistance, increasing the blood pressure. This increase in blood pressure, if it is strong enough, it will stimulate the baroreceptor reflex, and as a result, baroreceptor reflex will result in reflex bradycardia. Okay, so these are the major actions of alpha-1 agonist on cardiovascular system. So we can say that because they increase the peripheral resistance, we can use them when there is low peripheral resistance. When peripheral resistance is low, and we know that when the peripheral resistance is low, that means there is low blood pressure. So this is the main use, low blood pressure. So they are used in cases of low blood pressure to increase blood pressure. Okay, in two cases, as we will explain now. So these drugs, by producing vasoconstriction, they increase the peripheral resistance and therefore they increase the blood pressure. So once they increase the peripheral resistance, that means they have very important clinical application in cases of low peripheral resistance, which will result in low blood pressure, which is known as hypotension. So these drugs are used in cases of hypotension. Okay? Now, so how they are used in hypotension? So we said that alpha-1 agonist will result in increase in peripheral resistance, which will result in increase of blood pressure, and therefore they are used in cases of low peripheral resistance and, of course, low blood pressure. This case of low blood pressure, which is known as hypotension, and if the hypotension is so severe, it can lead to shock. Therefore, these drugs, they are used specifically to increase blood pressure, especially when there is a low peripheral resistance, as in the case of use of spinal anesthesia. Spinal anesthesia, they usually use local anesthetics. They use local anesthetics, and as we know, local anesthetics will anesthetize all the nerves, including the sympathetic nerve, and if sympathetic nerve is anesthetized, that means there is no tone to the smooth muscle or blood vessel, and this will lead to vasodilatation. And the vasodilatation will result in decrease in blood pressure. So this is one of the clinical application. So it is used to increase blood pressure in cases of low peripheral resistance and the use of local anesthetic. This is very commonly used. Also, they are used to maintain blood pressure during certain surgical anesthesia. Of course, these are intraoperative, and usually they are used by intravenous injection. And the most commonly used in this case is methoxamine and phenylephrine, which we will talk about later, inshallah. Phenylephrine is another choice which is used intraoperatively to increase the blood pressure in cases of surgical anesthesia. Okay, so this is the first use, which is used acutely in certain cases of surgical anesthesia. Some people, they suffer from what's known as chronic orthostatic hypertension, where these people, once they stand up, they suffer from dizziness because of the lower blood pressure while standing. These people usually, they are given orally active alpha-1 agonist midodrine. So midodrine is used in cases of chronic orthostatic hypotension. Chronic hypostatic hypotension, these people usually, when they stand up from supine position, they suffer from dizziness because of severe drop or sudden drop of blood pressure. So usually midodrine is given in this case orally. Okay, so these are the first, which are alpha-1 agonist, and we have taken two examples, midodrine and methoxamine. Second group of selective sympathomimetics are selective beta-1 agonists. We'll take two important examples in this case, Dobutamine and Dopamine. Dopamine actually is not very selective, as we will see later, but it is important to speak about it in this place. Dobutamine is a selective beta-1 agonist. As we know, beta-1 stimulation will result in increase of calcium level in the heart, will lead to increase of calcium level, and this increase in calcium level will increase all conduction rate, heart rate, and heart contraction. So all the functions in the heart will be increased by stimulation of beta-1 receptors. This increase in conduction rate and contraction at a specific dose will result in increase in cardiac output. Cardiac output will be increased. And we expect therefore that by increasing the cardiac output, this will increase blood pressure. Okay? So in this case, we can say that dobutamine can be used in cases where there is low cardiac output, accompanied by low blood pressure, as in case of acute heart failure. So acute heart failure, usually there is a decrease in cardiac output. This is why it is called heart failure. Heart failure means a decrease in cardiac output. This decrease in cardiac output will be accompanied by decrease in blood pressure. So dobutamine in this case, dobutamine is selective. It is used intravenously in acute heart failure. It is given by intravenous injection. Therefore, this is very important clinical application of dobutamine. It is given in acute heart failure to increase the cardiac output and therefore will increase blood pressure. We know that the low blood pressure produced by low cardiac output, if it is severe, it leads to what's known as cardiogenic shock. Cardiogenic shock. Therefore, in cardiogenic shock, and it is from its name, cardiogenic, means that severe drop of blood pressure as a result from severe drop of cardiac output. This is known as cardiogenic shock. So dobutamine is used intravenously in this case. The second drug, which is dopamine. Dopamine is acts centrally as a neurotransmitter in the brain, and it has very important clinical application. Dopamine, as we know, it is a catecholamine where it will act on beta-1 receptors of the heart. It acts an agonist, direct agonist on beta receptors of the heart. By acting on beta-1 receptors of the heart, it will increase the cardiac output, and by increasing the cardiac output, it will increase blood pressure. So this is a beneficial effect of dopamine. It can increase blood pressure in case of low cardiac output. Okay? If we use a higher dose of dopamine, it can act on alpha-1 receptor as well. It will act on alpha-1 adrenergic receptor. And we know that alpha-1 adrenergic receptor will produce vasoconstriction, and by producing vasoconstriction, blood peripheral resistance will be increased, and blood pressure will be increased. Okay, so in lower doses, dopamine will act specifically on beta-1 receptor, increasing the cardiac output, therefore increase the blood pressure. In higher doses, it will act as well as alpha-1 agonist, producing vasoconstriction, increasing the peripheral resistance, and increasing the blood pressure. There is a third action of dopamine where it will act on dopamine receptors which are present on the kidney, dopamine receptors in the kidney and renal tubules, where stimulation of these dopamine receptors will increase glomerular filtration, which is usually compromised when there is a decrease in blood pressure. When there is a decrease in blood pressure, usually glomerular filtration will be decreased, the kidney function will be decreased. Therefore, dopamine, by acting on dopamine receptors in the renal tubules, it will increase glomerular filtration, and this will result in improvement of renal function. Improvement of renal function. This is very advantageous. Why? As we have said, because usually when there is low blood pressure, there is low glomerular filtration. By improving glomerular filtration, this will improve renal function. So that's why dopamine is very useful in all types of shocks, It is used usually by intravenous injection. It is used to increase the blood pressure and improve renal function in all types of shocks, whether it is cardiogenic or otherwise. Okay? So these are the most important selective beta-1 agonists. Dobutamine, which is a selective beta-1 effect, it will increase cardiac output, increasing the blood pressure, and therefore it is used specifically for cardiogenic shock. And dopamine, which acts on beta-1, alpha-1, and dopamine receptors, and it can be used for different types of shocks. So these are the selective beta-1 agonists. Next group will be the selective beta-2 agonist. And beta-2, as we said before, it is important for us both the bronchioles and the uterus. They have important clinical application regarding these two organs. Okay, beta-2 always قلنا they are inhibitory. It means that they produce smooth muscle relaxation, smooth muscle, and we have described the mechanism by which they do that in the last presentation. Therefore, in bronchioles, they produce bronchodilation. This has very important clinical use in treatment of bronchial asthma, and other chronic obstructive pulmonary diseases. Therefore, these drugs, beta-2 agonists, are used in treatment of bronchial asthma. They are drug of first choice, and they are used as well in treatment of chronic obstructive pulmonary diseases. Examples include the very oldest, salbutamol, which is Ventolin, known as Ventolin. This was one of the first beta-2 agonists introduced into the market for treatment of bronchial asthma. There are many other examples, including terbutaline, and ritodrine. There are tens of examples, like these are the most important examples, and I will tell you why. Salbutamol, terbutaline, and ritodrine. What's the difference between these three drugs? There is actually no pharmacological difference except in their kinetics. Salbutamol, it has a short duration of action. It acts for 4 hours, short duration, while terbutaline is an example of long duration. It acts for many hours, maybe 8 hours or more. And ritodrine, the same thing, it has long duration. Ritodrine, although it is beta-2 agonist, it has specific application, as we will see later. Okay, so these drugs, they are usually used for treatment of bronchial asthma, and for these they are given the common method of administration. They are given by inhalation. This is the very common use. They are given by inhalation to have a local effect and less systemic side effects. However, sometimes they can be given by oral route of administration in certain cases where the patient cannot inhale. Okay, in this case they are given by oral route. If they are given by oral route, usually they produce more side effects. Or more systemic effects. They produce increase in heart rate due to beta-1 effect, because they are not very selective, especially when they are taken orally. Usually they are used in higher dose. When they are used in higher dose, their selectivity will disappear, and therefore they will produce increase in heart rate or tachycardia. Okay, this is the most common side effects. They can produce slight anxiety and tremor. These very common side effects when they are taken by oral route of administration. So these are the selective beta-2 agonists. They have very important clinical uses in treatment of bronchial asthma or obstructive pulmonary diseases. Other important organ is the uterus, and as we know, beta-2 agonists in the uterus, they produce uterine relaxation, and this uterine relaxation, it has very important clinical application in treatment of what's known as premature labor. So they are used in premature labor, where pregnancy is terminated before term, and in this case they are used for a longer period of time, and they are taken orally. The most commonly used in this case, which is marketed for this purpose, is ritodrine and its congress. So ritodrine was licensed in USA or given FDA approval for use in treatment of premature labor. Okay, so these are the selective beta-2 agonists and their clinical. Next group will be the non-selective sympathomimetics. Non-selective sympathomimetics, we mean that they have affinity to different types of adrenergic receptors, including LB1, B2, and alpha-1 and alpha-2. So we start with adrenaline. Which is known as epinephrine. Adrenaline, as we know, acts as a neurotransmitter, and it acts as well as a hormone, where it is released from the adrenal medulla, and it is transported by blood to act on different adrenergic receptors in the body. And as well, it has very important clinical application, as we will see in a few moments. So adrenaline, it acts on all adrenergic receptors. It acts as an agonist on all adrenergic receptors, where it will act on all alpha-1, alpha-2, beta-1, and beta-2. It acts as an agonist on all adrenergic receptors. However, this affinity to different adrenergic receptors or selectivity depends on the dose of adrenaline. Okay, so if we use, for example, small dose of adrenaline, small dose, when we say small dose, that means lower than the therapeutic dose. If we use smaller dose of adrenaline, it will act as a beta-2 agonist. It will have more affinity to beta-2 receptors at small doses, beta-2 agonist. That means in small doses of adrenaline, it will act as a beta-2 agonist on blood vessels. So what you expect will happen? What will happen in this case? So by stimulating the beta-2 receptors on the blood vessels will what? Dilate or contract? It will dilate. So vasodilatation will take place. If vasodilatation takes place, what will happen to the peripheral resistance? Decrease, of course. Decrease in peripheral resistance. Once decrease in peripheral resistance, what will happen to the blood pressure? Blood pressure will be decreased. Okay? Therefore, small doses of adrenaline, small doses lower than the therapeutic dose, adrenaline will have more affinity to beta-2 receptors, producing decrease in peripheral resistance and therefore decrease in blood pressure. Okay? Now, if I use the normal therapeutic dose of adrenaline, adrenaline in this case will act as alpha-1 agonist, beta-1 agonist, and beta-2 agonist as well. So it will act as an agonist at the 3 different types of receptor. So what do you think will happen to the blood pressure in this case? What do you think will happen? Because we know that alpha-1 on blood vessel and beta-2 on blood vessel, they have the opposite action. Alpha-1 produce constriction of blood vessel, as we have explained many times, while beta-2 produce dilatation of blood vessels. So what will happen in this case? What will happen? Of course, at the normal dose, adrenaline, it has more affinity to alpha-1 receptor. So what we will see? If we inject adrenaline? I'll see alpha-1 effect, so increase in blood pressure. I will see an increase in blood pressure. This is an alpha-1 effect. So adrenaline in the normal therapeutic dose, it will produce an increase of blood pressure plus slight decrease at the end of the effect. This slight decrease is due to beta-2 effect. Okay? To beta-2 effect. So therefore, adrenaline in a normal dose, it will act as an agonist on alpha-1 receptor, which are producing vasoconstriction, increasing blood pressure, and as well it will act on beta-2 receptors, decreasing blood pressure. Therefore, they say that adrenaline does not have a pure pressure effect. Does not have a pure pressure effect, as the case of noradrenaline. In the case of noradrenaline, which we have explained in our last presentation, we said that noradrenaline, by acting only on alpha-1 receptor, because it has no beta-2 action, it will produce pure pressure effect. This pure pressure effect, we have explained in our previous presentation, will stimulate the baroreceptor reflex, which will decrease the heart rate, and we said it can produce bradycardia, reflex bradycardia, as we have talked about methoxamine. Now, this is not pure pressure effect. Adrenaline does not produce pure pressure effect. Therefore, there is no reflex. It will not stimulate the baroreceptor reflex. Therefore, there is no reflex bradycardia. Okay, so adrenaline never produce reflex bradycardia. Why? Because it has no pure pressure effect. Okay, so alpha-1 will produce vasoconstriction of blood vessel, beta-2 will produce dilatation. So there is a pressure effect, increase the blood pressure, plus slight depressor effect because of beta-1, beta-2 effect. Of course, on the heart, the beta-1 will produce tachycardia, increase the heart rate, increasing the cardiac output. Okay, therefore, adrenaline in a normal dose can produce increase in the mean blood pressure plus tachycardia. So this action of adrenaline on blood vessels. So what will happen to the bronchioles? Because we said that adrenaline will act on alpha-1, beta-1, beta-2. Alpha-1 we said will increase the blood pressure. Beta-1 we said will increase the blood pressure to increase the cardiac output. Correct? The beta-2 effect we said will decrease the blood pressure slightly, and especially in small doses of adrenaline, and as well it produces bronchodilation. As we have said before, beta-2 effect on the bronchioles is relaxation producing bronchodilation. These effects of adrenaline, they have very important clinical application. Maybe the most important clinical application first, so I'm talking about clinical uses of adrenaline. The very first important clinical use, they're using anaphylaxis. Anaphylaxis or anaphylactic shock. Anaphylaxis or anaphylactic shock. Usually this is an allergic reaction to any foreign antigen. The body will consider it as antigen. It forms antibody, and this antigen-antibody reaction will result in severe allergic reaction with the release of many mediators, including histamine. Histamine, what will do? It will act on histamine receptors, producing vasodilatation, H1 receptor in the blood vessel, producing vasodilatation. It will act on H1 receptors in the bronchioles, produce bronchoconstriction. And produces bradycardia and other bradycardia and decreasing cardiac output and other symptoms like skin rash, like angioedema, etc. As we know, vasodilatation, that means produce decrease in blood pressure, and if this decrease in blood pressure is severe, it can lead to shock. That's why it is known as anaphylactic shock. Bronchoconstriction, you know it's dangerous. Respiration becomes very difficult. So in this case, for anaphylaxis, adrenaline is life-saving. Adrenaline is life-saving. Life-saving. Why it is life-saving? Why? Tell me. Just think with me. Why adrenaline? In this case, it is life-saving. Because if this patient who's subjected to allergic reaction is not treated immediately, he might die. He might die from severe respiratory arrest due to severe bronchoconstriction. He might die from the shock because of the severe drop of blood pressure. He might die from cardiac arrest. So in this case, we give adrenaline. Why? لأن adrenaline, it will act on alpha-1 receptor blood vessel, increasing the blood pressure. This is the first antagonism. Adrenaline, by acting on alpha-1 receptor, it will produce vasoconstriction, increasing blood pressure. So this is the first antagonism. It will act on beta-2 receptors in the lung, producing bronchodilation. This is the second antagonism. This is the first, this bronchodilation. Bronchodilation. This is second antagonism of histamine action. A third, it will act on beta-1 receptor in the heart, increasing the cardiac output. This is the third antagonism. So when we give adrenaline, we antagonized all the effects of histamine by adrenaline. What's the name of this antagonism? We have described it before when we talked about the general pharmacology. This is known as physiological antagonism. Physiological antagonism. صح? Correct? We called it physiological we called it physiological antagonism. Why we called it physiological? Why? Can you think with me? Why we call it physiological antagonism? Because both adrenaline and histamine, histamine acts on histamine receptor as an agonist. Correct? And adrenaline, it will act on adrenergic receptor as an agonist. So both of them, they act on different receptors. Adrenaline will act on alpha and beta receptors. Histamine will act on H1 receptors. They act on different receptors. What they do? They produce the opposite effect. That's why they are known as physiological antagonism. Physiologically, one increases blood pressure, the other decreases blood pressure. One produces bronchoconstriction, the other produces bronchodilation. One produces bradycardia, the other produces tachycardia. Okay, so they act oppositely. Each one will oppose the action of the other drug. This is known as physiological antagonism. So this is the first very important clinical use of adrenaline in treatment of anaphylaxis. As you have noticed that I don't concentrate on doses mainly. Usually I don't mention doses, except in this case I have to mention the dose. Why I should mention the dose? Because it is a life-saving. So usually the dose of adrenaline, in this case it is about 0.3 to 0.5 milligram. Usually they are given by subcutaneous injection. And the concentration of adrenaline is usually 1 to 1000, 1 gram in 1 liter, 1 to 1000. This will produce a dose of 0.3 to 0.5 milligram, and usually it is given by subcutaneous injection. Okay, so this is the first important clinical use of adrenaline. It is used in treatment of anaphylaxis. The second important clinical use of adrenaline, which we have talked about it before, is its use with local anesthetic. They are mixed. Adrenaline is mixed with local anesthetic. As we know, local anesthetics are used to produce a local anesthesia. Local anesthesia means anesthesia at the site of administration of these drugs like lidocaine and its congress. So usually in this case we want a local action. We don't want a systemic effect. Like when you go to the dentist, he will inject you with a local anesthetic so that he can produce a local anesthesia at the site of operation, for example. So in this case, local anesthetic, we use them to have a local effect. So when they are mixed with adrenaline, as we know, produces alpha-1 constriction, alpha-1 action, which is vasoconstriction. So vasoconstriction will take place at the site of the administration. This means that the local anesthetic will have a local effect, and once it has a local effect, that means we reduce the systemic effect, we reduce the chance of systemic effect, of systemic action, systemic toxicity usually. That's why we don't need it, systemic action. This is first, very important goal. So the first important goal is to reduce the chance of systemic action over the local anesthetic, which can produce toxicity. The second is to prolong the action of local anesthetic, because the local anesthetic will not be absorbed, it will stay at the site of administration, and its action will be prolonged. Therefore, prolong the action of local anesthetic. Okay, so this is the second very important use of adrenaline. It is mixed with local anesthetic to produce local vasoconstriction. Therefore, will decrease the absorption of local anesthetic. Therefore, it will have no systemic action, and we will have a prolonged duration of action of local anesthetic. This is the second clinical use. Third clinical use, third important clinical use, they are used intracardially. They are injected directly into the heart. This is known as intracardial injection. In cases of cardiac arrest, and we see in a lot of films, they say they inject directly into the heart, and adrenaline is the drug in this case. Why? Because intracardially it will act on beta-1 receptor in the heart, and by acting on beta-1 receptor in the heart, it will stimulate cardiac activity all. So this is the fourth use of adrenaline. It is used as a spray in ENT surgery to reduce bleeding during surgery. Okay, so this is the very first non-selective sympathomimetics, which is adrenaline, which has a very important clinical applications. Okay, second non-selective is noradrenaline. Noradrenaline, as we have said before several times, it is the main neurotransmitter. It is the main adrenergic neurotransmitter. Adrenergic neurotransmitter. Whether in the periphery or central, where it will act as a major neurotransmitter in the brain, and as well in the peripheral autonomic nervous system, and we have explained that several times. Okay, Now, adrenaline, as we know, it has only alpha 1, beta 1, and beta 2. Only alpha 1, alpha 2, and beta 1 effect. It has no beta 2 effect. It has no beta 2 effect. So we expect in this case that by acting on alpha 1 on blood vessels, produce a pure pressure effect. Pure pressure effect. And we said that in enough high dose, the pure pressure effect can stimulate the baroreceptor reflex, which can result in reflex bradycardia, as we have explained with methoxamine. Okay, but still in enough dose there is a beta 1 effect, and beta 1 effect can increase the heart rate and it can produce tachycardia. Actually, there are in high dose there are two antagonistic force, a force of baroreceptor reflex which try to produce bradycardia, and the direct effect through beta 1 effect which try to increase the heart rate, producing tachycardia. That's why noradrenaline in a certain dose they produce irregular tachycardia. Irregular tachycardia. I will not explain the mechanism of that, although it's not that essential in this phase. Okay, all we have to know that noradrenaline at a high dose to produce irregular tachycardia because of the two antagonistic force, the baroreceptor reflex which try to decrease the heart rate, and the beta 1 effect which try to increase the heart rate, and this will result in irregular tachycardia. Irregular tachycardia we mean increase and decrease of blood pressure regularly. Okay, so noradrenaline, it has no specific clinical application. Maybe sometimes it is used in treatment of cardiac arrest. Certain situation they found that noradrenaline might be better choice than, for example, alpha 1 agonist. We talked about them, like methoxamine, in treatment of certain types of cardiogenic shock or in cardiogenic shock or cardiac arrest. Okay, this is the only indication of noradrenaline. Okay, otherwise noradrenaline, it is a major neurotransmitter. It has very important physiological action which we talked about them. The autonomic nervous system actions, including effect on the GIT, effects on the eye, effects on cardiovascular system, and all those actions you have to remember. Okay, so the third is the third directly acting non-selective is isoprenaline. Isoproterenol is an agonist at beta 1 and beta 2 receptors. So we expect by acting on beta 1 receptors produce tachycardia, and by acting on beta 2 receptors it will produce bronchodilation. That's why some time ago it was used for treatment of bronchial asthma. Used for treatment indicated. Some preparation they still use isoprenaline, but actually now there are better choices, and as isoprenaline should be avoided. So some time ago it was indicated in treatment of bronchial asthma. Like now it's not first choice. Why it's not first choice? Because it is non-selective. It produces tachycardia as a side effect, and we have the more selective beta 2 agonist. Why we should use isoprenaline if there is other better choices? But as I have said, some preparations still in the market contains isoprenaline in treatment of bronchial asthma. So isoprenaline very rarely used in bronchial asthma, and it can still produce tachycardia as a side effect because of its action on beta-1 receptor. Very last, Phenylephrine, which we said some books they classify it as alpha-1 agonist. Actually, Phenylephrine, it is alpha-1 agonist. At higher dose, it will act as a beta-1 agonist as well. So Phenylephrine, in a normal dose, it will act as alpha-1 agonist. And at a higher dose, it will act as a beta-2, beta-1 agonist as well. Okay? So by acting on alpha-1 agonist, phenylephrine usually it is mixed with other drugs in the treatment of common cold. So mostly phenylephrine is mixed with other drugs, as we will mention later, in treatment of common cold and allergy. Why? Usually allergic reaction of the nose, and in a common cold there is vasodilatation. This vasodilatation will result in congestion of the nose. احتقان. Congestion will lead to congestion of the mucous membrane of the upper respiratory tract, and usually this is accompanied by rhinitis, سيلان الأنف by rhinitis، وكذلك and conjunctivitis. التهاب الملتحمة متاع العين conjunctivitis. Okay, rhinitis and conjunctivitis. Okay, so in this case what they do, they give phenylephrine by acting on alpha-1 receptor. Phenylephrine by acting as alpha-1 agonist produce vasoconstriction of the mucous membrane, and this vasoconstriction of the mucous membrane will decrease the congestion احتقان بالعربي، will increase the congestion in the mucous membrane. By decreasing the congestion in the mucous membrane of the upper respiratory tract, they produce what's known as decongestant effect. Decongestion. They call it decongestion. So this is the very common use of phenylephrine. It is mixed with other drugs in treatment of common cold, symptoms of the common cold, and as well in treatment of symptoms of allergy, in which there is a vasodilatation, which will result in congestion of the mucous membrane of the nose and the eye. Mucous membrane of the nose will lead to what's known as rhinitis, and congestion of mucous membrane of the eye will produce conjunctivitis or conjunctiva. And in this case, the alpha-1 phenylephrine, when it is taken, it will act on alpha-1 receptors on the mucous membrane blood vessels, producing vasoconstriction, reducing the size of the mucous membrane, i.e. they reduce the congestion in the mucous membrane, and this is known as decongestant effect or decongestion. So phenylephrine is commonly used in oral preparation, which are used for treatment of common cold and allergy, and also they are used topically as drops, either nose drops or eye drops. They are very commonly present in oral preparation as tablets or capsules, and also they are present in eye drops or nose drops, which are used in treatment of common cold and allergy symptoms. So these are in general the directly acting sympathomimetics. So in summary, what we have talked about today, we talked about alpha-1 agonists, and they're used to maintain blood pressure intraoperatively during spinal anesthesia, and orally for chronic orthostatic hypotension. We talked about the use of beta-2 agonists in treatment of bronchial asthma, chronic obstructive pulmonary disease, and in premature labor. We talked about the use of beta-1 agonists in the treatment of cardiogenic shock. We talked specifically about adrenaline and how it is used in treatment of anaphylaxis, and it is life-saving in this case, how it is mixed with local anesthetics, and how it is sprayed over mucous membrane to decrease surgical bleeding. We talked as well about phenylephrine and noradrenaline. In our next lecture, inshallah, we'll finish talking about the indirectly acting. Today we talked about the directly acting. Next lecture we'll talk about the therapeutic actions of indirectly acting sympathomimetics. I would like to thank you very much for your attention and hope to see you again in the near future. Thank you very much, and Assalamu alaikum wa rahmatullahi wa barakatuh.